All right. Hi, everyone. Um, Thank you, Viva Learning and GC America, for having me on and speak a little bit about injectable composites and how I incorporate them into my private practice. My name is Nader Yermian, and I'm a dentist in LA. And we've going through a lot of stuff right now. I'm sure everyone knows about the fires, and I literally just got a emergency warning, like to evacuate. Although it seems pretty calm, and we're so far okay. I'm grateful that the office and my home is fine, but and I have friends and patients that were affected by the fires, and my heart is with my fellow Angelinos, and it's very devastating, and it's probably gonna be a long road for recovery, and I'm heartbroken and devastated. So if you guys have anyone in the LA area, just reach out to them and make sure they're okay. I'm sure everyone knows someone that's affected by it, so my heart's with them. But so going back to the topic of injectables, I'm sure some of you guys want to know, who is this guy? I'm not famous dentist. I'm just a private practitioner. I own a private practice in LA called Vicente Dental. It was a startup, and it was 2018, and I associated many years before, and I used my platform, I guess, online to help create this private practice. And I had the honor to work under Dr. Pascal Magnier, who's sort of the leader and forefront of biomimetic dentistry. I use biomimetic philosophies and minimally invasive philosophies into my private practice, and I was able more or less to build my brand that way and my private practice that way. And I started off small, and I'm currently in the middle of an expansion, which is exciting. Um, I did, and I still use a lot of composite dentistry in my private practice. I think it's a great gateway to do bigger, advanced cases. In porcelain or bigger complicated cases, composite's fairly cheap and easy, and it'll help you with your techniques. And the more you do them, the better you'll get at them. Instagram has been a big platform. This is sort of my one viral moment. I haven't had many, but I had one viral moment during the bottle cap challenge where it only took 30 tries to get this down. But I think it's important to have a nice social media page so you can post some of your cases, and it's certainly helped me out with my practice. So, what is biomimetic dentistry? To me, it's I believe that it's sort of the way I practice is in a very minimally invasive way, and that's what I believe. My father, at the time I started dental school, he had dentistry, and he had dentures, and he've always said, "Hey, Nodder, just always be, don't rush to pulling teeth, don't try to be aggressive," and that always stuck with me. So my approach to dentistry is try to keep as much tooth structure as possible when I can. Try to mimic nature, when I can, and that's kind of what biomimetic is copying nature. And if you get really good and you get comfortable with adhesion and your bonding techniques, there's really no need to cut a crown or be aggressive in your preparations. And tooth conserving is sort of my philosophy. If anytime I can, I try to conserve as much enamel and tooth structure as possible. This is sort of my biomimetic protocol or checklist. It's a lot. It could be overwhelming, and you could also cherry pick what works best for you. And but I feel like if you have a good understanding, then you're able to cherry pick better. Isolation. If you could throw a rubber dam on, obviously that's the best type of isolation. Do I use that every single time? No, but I try to. Understanding your bonding agents, when to use a universal or two-step prime and bond. Understanding, composites very technique driven, so understanding C factor and interlayering. For my luting agent, I pretty much now use injectable composites, instead of preheated composite. And I'll briefly talk about that. But this is by biomimetic protocol. Feel free to take a screenshot or a photograph. And really to understand biomimetics, I think it's really important to understand the bonding agents and what you could use. I sort of simplify things to like a one-step versus two-step. You have your universal agent, and then you have a two-step agent. Anytime my preparations are all within enamel or majority enamel, I think a universal agent is fine and it's wonderful and it makes life easy. I use G Premium Bond for anytime I do a composite injectable or class ones, class twos, shallow fillings. It's a very great bonding agent. And I use it predominantly in my practice. Anytime I need more dentin bonding, let's say for core buildups or class fives or deep decay, or for immediate dentin sealing, when you really want to seal the dentin well, I use a two-step agent, such as G2 bond or Optibond FL. And the reason why is you want to really treat the dentin separately, and you get better dentin bonding this way. Speaking of immediate dentin sealing or dentin sealing, sort of the minimal protocol for it, when it comes to maybe the biomimetic gold standard, it's often considered Optibond FL. And when you use Optibond FL, you don't necessarily need to add a flowable, but with G2 bond or other bonding agents that are thin, it's beneficial to add a little bit of flowable as a final cure, because you want to make sure that the agent is fully cured. It's so thin that the oxygen inhibition layer might not fully cure the agent unless you put a thin flowable. And you could do some extras with your IDS, and you could air braid or scrub with chlorhexidine 2%, with the immediate dentin sealing if you do that prior to your final impression for indirect restoration. But for the majority of these cases, I do use G Premium Bond, which it's my favorite bonding agent, at least universal agent. And for cases where I'll do where it requires more dentin bonding, this is my go-to agent, bonding agent, which is the G2 bond, which you treat the dentin separate to the enamel. So the dentin gets treated with the first step. Now I definitely etch a little bit, but I don't leave it long because you don't want to over etch it. The priming agent has etch. But you also have to follow the user manual because not all bonding agents handle the same way. At USC, which is where I went to school, we were taught to use Optibond FL, and the bonding agent with Optibond FL is different than G Premium Bond. Just make sure you follow the user manuals. All of them are a little different. With G Premium Bond or something that has solvent in there, you have to really air dry it. Otherwise, it won't fully cure. So you can see this demo, you didn't dry it and it's not cured, right? And if you're in the habit of doing the way that you might use a different bonding agent, then you're going to have failure and debonding and maybe post-op sensitivity. And you can see this is the bonding agent for Optibond FL. Once you cure it, it fully cures. So I handle these agents differently when I'm using them. So just make sure you follow your user manual depending on the bonding agent you use. Let's talk a little bit about universal injectable, which I think this stuff is just magic. I don't believe there's anything else out there that's like this material. It's a flowable, but that acts like a packable. It has very high flexural strength, like a packable. It has this homogeneous particle that's dispersed with silane coating, so it makes it so it just lasts really long. It doesn't chip away, and when it wears, it sort of keeps it a glossy appearance. The aesthetics is wonderful as well. So I use it daily. I use it all the time, and it could probably replace all my packable, but when I layer my restoration, sometimes I find a need to use packable, and I'll show you some cases where I do both. And you could see in this slide where thicker filled particles, when they pluck off, that they cause bigger chipping and bigger discoloration, whereas The injectable really doesn't have that problem. And I'm not sure if you guys follow Dentinal Tube, but you could see they had a demonstration and several flat slides on injectables, and this one really spoke to me. I mean, you could see how the injectable just stays up in place. It doesn't really flow everywhere, which is why I like using them sometimes for anatomies, for marginal ridges and cusp. And I love them for indirects. Prior to using injectables, I use heated composite to cement my veneers and my inlays and onlays, but I find this material so much easier in my hands, and it doesn't flow everywhere when I try to clean it up. So, and if you have a little excess, you're able to clean it easier than heated composite. There's also a brand of injectables with fiber in them that I've used now to replace anytime I would place a post traditionally. I use it from all my core buildups. It's called Fiber X Flow. So let's begin with this first case. This is more or less, in my opinion, the best case you could use injectable composites, peg laterals, diastema closures. She has open private space in the mesial of the canines. And she just finished ortho, and this is the way she presented. And she was unhappy with the shape and size of her teeth and her smile. So she's a great candidate for injectable veneers. First things first, every patient that comes to my office takes an intraoral scan. And we use our iTero to scan everyone for now. And I'm not her general dentist, so I didn't restore any of her class 5s, but that was, she only really came for me for the composite injectables, the composite veneers. And from here, we get a digital smile design. And then I've got a 3D printer, so I'm able to 3D print the design. Now, to make life a little easier, you could always use the every other tooth design option as well. So for example, for this case, we're really treating 4 teeth. So one model will have 7 and 10, or it could just have 6 and 11. And the other model will have every single tooth option. And you make matrices with both of them. And it just makes, shaping the composites a lot easier when they're separate. And also, you don't have to worry about them getting stuck with the adjacent teeth. If it just makes life easier. Trust me on this. And I'll show you why. This is the matrix that we use, Exa Clear from GC. It's very clear. It's very easy to handle. This is one of the ways we do our matrix making. And if I do this when I don't have enough time, let's say, there's a different way I make matrices now, and I'll show you that in the second case, but you just place them on, and you have to use soap to more or less push it into place and form it into place. Otherwise, it'll just stick on your gloves. You can't use glycerin or Vaseline either. It has to be soap. And you just kind of sculpt it and play with it. And then when you feel like you have uniform thickness and you're happy with the way that it looks and it's formed around the model, you just set it down and let it sit for as long as you can. You can also put it in a pressure cooker to help strengthen the matrix. So gives you a quick little demo of how we make the matrix. And and sometimes I just don't have the matrix ahead of time, so we have to make it this way. So you can see how we have it on both study models. And to poke the hole for the injectable, you go from inside out. So you kind of make sure you go back and forth a few times to make sure you don't have any excess silicone matrix in there, because you don't want that to bond into the composite injectable. Briefly, let's talk about isolation, split versus individual rubber dam. The window or split technique just really makes it a lot easier to place the matrix, although it's not the most isolated way. It does really help to retract your lips, tongue, cheeks, saliva. You still often have to place cord, but it makes it a little easier to do than the individual isolation technique with rubber dams, but which creates better isolation. But I don't always use that way. I do it on selective cases. One thing is that you do require a little bit more numbing and clamps when you do the individual technique versus the window technique. My anchor clamps, so for mandibular molars, I use 26Ns, maxillaries are 27s, premolars W2s. These are non-aggressive, they're gentle on the tissue, they hold really well, but sometimes you might need some big boys, which are these aggressive clamps, the 12A and the 13A. They're serrated, so they stay in place really well. Auxiliary clamps, in addition to your anchor clamps, the Brinker clamps are really wonderful. The Calmer clamps are great. Heath has some really good ones as well, and you can see how you use those in conjunction with an anchor clamp. These might have to play with the B5 clamp. We heat it with a torch and bend it so we could get a better adaptation on the cervical buccal area there. And you always have to use heavy. It's really important if you use a heavy dam. Medium is really good for endo, in my opinion. I don't do endo, but otherwise it'll just tear. And you could get better isolation with a heavy dam. All right, punching the holes. I rarely use the biggest one. I always think it's too big. I err on the smaller hole size. So for my anchor clamps, I'll pretty much always use the second biggest one. And the mandibular incisors are often the smallest ones. Sometimes pec laterals will be the smallest hole as well. And really depends on what kind of punch holder that you have. Sometimes they're 6, sometimes they're 5, but I would err on the smaller size hole per tooth. And this kind of gives you a picture of what a split dam, the way I do my split dam, cut into a triangle like this. And I'm using my my anchor clamps there on the first molars. A little bit of anesthetic to make it comfortable, well, not too much. But then again, if I'm going to core the tissue, I might add a little bit as well. And I went ahead and placed a little bit of cord to get better retraction and isolation. From here, you want to make sure the matrix is seated. So you just try it in before you start the process and you microbraid the teeth. I used right now currently use the Rondo Flex, which is the top right one. It just hooks up on my chair, just pretty small and convenient. Prior to that, I was using like a cheaper micro braider that you see. The Aquacare is the Rolls Royce. I don't have that in my office, but it's probably considered one of the better microabrasions. I just I have a small space, so I try to I can't really I have limited space, so I'm quite pleased with the Rondo Flex, and I just kind of leave it on my chair. It hooks up to the chair unit. Once you abrade it, you rinse it and dry it. You isolate some more with some Teflon. You start etching, and you're getting ready for the injectable, the first part on 7 and 10. A little bit of G Premio Bond on 7 and 10. And you inject the composite through. And you want to make sure you don't want to press it too hard, but apply some pressure by the gum line so you don't have it seated all the way. But in terms of the excess, you could just use a 12 blade afterwards to kind of clean it up. You might have a little hemorrhaging, so you could go ahead and place a little bit more viscostat or put another cord, but then you gotta do the same exact thing on the canines. You etch it, you get ready for adhesion of the bonding agent and the injectable. So 12 blade is very handy. I use it, even it's a surgical blade, I use it every single time I place composites. For this little incisable chip, I went ahead and restored that with their packable composite, even though I could have easily done injectable. Sometimes I find it a little easier to use the packable to sculpt. And GC has a core that I use for my packable composites. So this is what it looks like immediately after removal of the matrix. And we go ahead and air block with glycerin and light cord, glycerin, and we cure it. You don't have to spend too much time polishing with the matrix technique. I use a 7901 carbide to go underneath the gums. And you can use a soft disc to help with the marginal, sort of the marginal or mesial distal line angles. I mean, air blocking is really important. It sometimes gets neglected. I like to do this before I stop polishing because the composite material could get stuck on the polishing, then it won't really polish well. So, I use some glycerin and just cure that. Then I start my polishing. And these are sort of my new favorite polishers called the Eve polishers. I get these at Eagle. They're Eagle dental burrs, I believe. And I use the Jiffy Go Hair from Alterdent for final polishes. So the teeth are going to always look a little bit rare because the other teeth are dehydrated. And a couple week follow-up, that's what they look like. And yeah, you could see how she smiles now with she has a bigger smile, and the composite veneers or the composite injectables just kind of fills that area a lot better and fairly simple to do. So she liked the work so much, she referred her friend to me who pretty much had this very similar situation. She also had the peg laterals and open spaces she wanted to close. Her teeth were just a little bit different in terms of I felt they had more transparencies in them, and I wanted to add that to the material. So, in this case, we're doing a layer technique. We're doing a combination of a little bit of packable and then injectable over it. So same sort of concept. We have a DSD or digital smile design. From here, we make our putty matrix. Now, if I have more time, this is typically the way I do my clear matrix is I do a suck down over the putty matrix, and then I squirt the silicone, the clear matrix, the clear silicone into the Essex, and I allow this to set. So this is how I typically make these clear matrices. I go ahead and start isolating with cords, and I make sure I airbrade, make sure the matrices seat all the way. And you can kind of see how I need a little bit more clearance for if I'm trying to recreate transparencies here. So I just have to make sure that there's a little bit of space for that material. So I kind of buff that out a little bit to kind of create better aesthetics. I isolate, I etch, and I place bonding agent, and I go ahead and start with my paddle shell. So I use that same matrix and I cut it, and I'm able to add my first layer, which is the lingual shell with packable composite. And you could have fun and add a little bit more tinting to this. And I like to add this little halo where I add a little bit of white, or you could use ivory white. If you add white, then you might want to mix it with just a little bit of orange to create a nice little halo. And you just kind of put that on the very edge of the incisal. Then from here, you go ahead and now do the same exact way as we did before with the previous case. You try the clear matrix, make sure it all fits, and then do the injectable technique. Each tooth at a time, one at a time. Now, I'd be lying to you if I tell you that I don't run with bubbles or issues in the material, but luckily with composites, easily repairable. And I repair them a little differently depending on when I'm repairing them. If it's immediate versus a delayed, let's say it's a repair like that we're doing in follow-up or, later on, years later, months later, versus one that I'm doing on the spot. For immediate repairs, often I notice these when I'm polishing back or cutting back. So I don't necessarily need to add air abrasion. It's already sort of rough, but I etch with phosphoric acid. And the mount typically is on the smaller side. So I add a little adhesive, thin it out. I don't really cure it at this point, but I add some composite over it and I'm able to push it in more. So it kind of goes into all the little cracks. And I feel a little bit better about it that way, that it's penetrating all the way through. It's not leaving a void. And the map's minimal, so I'm not worried about the curing like penetrating all the way through. Versus a delay technique, let's say I end up seeing this and want to repair this weeks on later, months on later, then I'd most likely air abrade the area or remove it, macro abrade it, create a little bit of a bigger surface, etch it. There are studies now that show that silaning will actually make the composite repair better and stronger. And before I only did this with porcelain, but now I do this with my composite repairs as well. I thin out the adhesive similar to I do with immediate ones, and I most often cure it, but it really depends on the size, right? Um, and then you add the composite afterwards. And so just like her friend, she had that little chip. I went ahead and I just restored that as well on the spot. You could see how right now the area looks really trans, right? Because I'm doing a layered technique. The paddle layer that I use is a transparent layer. And it's going to always look like this immediately after because the teeth, again, are so dehydrated. You got to have to give it time for the teeth for the water to stabilize again and for the teeth to rehydrate. This is the follow-up in a few weeks, and obviously it looks a lot better now. And we have, you have that transparency and a little bit of that halo as well on the incisal edge to give her the smile. Now, this is similar situation. She has more of a true peg lateral, but in this case, I wanted to do injectable on the dentin enamel. So we go ahead and we have her come in, and I did a little bit of a gingivoplasty with laser prior, and I kind of regretted that, and I'll tell you why in a second. So same concept. You can see in the scan her tissue is a little red here. We scanned it, we send it out. We got a molding for a dentin, and then molding for the enamel, which is the outermost molding. Same window technique. We verified the seating of both matrices. And then we retract with cord, we etch, placed our bonding agent. Prior to that, we air braided, all the same steps, and we go ahead and start. And obviously with this shade, the first shade we'll use is a dentin color. GC America has like an A01 or A02 that we could use. You could see that I struggled a little bit here with the bleeding more than I liked, and probably because I lasered the tissue prior and it wasn't fully healed. And I'll show you how I address that later. But I was able to get good enough retraction and isolation with cord. I just needed some time. And but I wasn't very secure about it. So this is why I went back into the area. I went ahead and made sure I made the palatal matrix off the matrices as well. Created a palatal shell with a very transparent, the white halo, and then we go with the facial injectable. So immediately after, and it looks like it needs some healing. It doesn't look great off the bat, but I knew I had to bring her back anyways, especially because I felt like I wanted to isolate again. So this is what she looks like in her follow-up. And we go ahead and kind of start the process again, and we focus on our repairs. I retracted, and I was able to retract it this way. I tried to do this technique initially, but her peg laterals are so barreled, I really had a hard time keeping them up, even with the floss ligation technique. But now, since the shape of the restorations of the teeth are a little bit more triangular and they're better, I could keep these up higher. And I was able to do it this way and not worry about the blood getting in the way. We retracted. I pretty much removed some of the composite by the gum line and more or less resurfaced or redid the last part of that, the second stage, the enamel part of the injectable. These are the steps that we did with the delayed repair technique. And we pretty much did that with all the teeth. And now I have a better result, and I feel a little bit more confident about the isolation. So before and after. Sometimes you could do the inverse. You could do injectable on the back, on the palatal matrix, and you could do a packable on the front. So let me show you how I did that. Her primary concern were that her teeth were barreled. The space and embrasures in between each teeth were too big. So she didn't like that. She was like, it felt like a shark. So we went ahead and corrected that with her. Composite is great. It's the most minimal invasive. So, she actually drove out to San Diego to see me because she saw some of my stuff on Instagram. This is actually before I had a printer, but if you end up using a lab, if you don't have a 3D printer, you just have to really communicate with them because you want to tell them where you want to do it. In this case, you don't want to just tell them wax up teeth. You have to be specific. Hey, wax them up on the corners, and really that's it because the facial looks fine. She doesn't need more volume there. You just really just want the corners a little bit thicker. Um, so we go ahead and make the matrix from here. And we do more of a individual rubber dam technique, make sure it's seated, but you can see how I'm struggling here on that clamp. So you just have to keep on modifying and cutting to make sure it seats all the way. And we do all the same steps, microbraid, etch, bonding agent. Now this is where the injectable comes in for this particular case. And we insert down the lingual and we cure it. So since it's still, even though it's a flowable that's not completely runny, it is more runny than packable, and they connect. But one way to fix that is with a 12 blade and the series saw to open up the contact very carefully. Do this slowly. Then you're able to get a Teflon tape through. And then from here, for me, it's a little easier in my hands to just use packable, kind of coat the area and sculpt that area facially. And then we go ahead and polish it up for her once the rubber dam is gone. And this is what she looks like. Now, injectable techniques are also very handy for just regular diastema closure. So this particular case, she just really, that's all she hated was that space. And so that's all we really focused on. We went ahead and did the whole DSD study models, print out the matrices. We isolated her teeth. We tried on the matrices, make sure everything fit, and we started the process. One tooth at a time. Start off with the canine here, but you could have done the lateral as well. Paddle shell first, add a little bit of halo. Go ahead and now add a more, transparent shaded of injectable in the front. But I use their enamel shades. I don't go full transparent because my paddle shell is going to be transparent. So I use their like a body shade, like a B1 or A2. Otherwise, the tooth itself might appear very gray. You don't want to do this in adult enamel or junior enamel or just pure transparent. You want a normal shade of composite. And then once I was complete with the canine, I'll go ahead and do the same thing with the lateral. But in this case, I ended up using a little bit more packable in approximately, as you could see. And part of the reason is that I was worried about cleanup afterwards. I feel like if the injectable, if I injected it through the matrix, it would have gone all the way through on the lingual, and it would have been maybe more of a challenge to kind of clean, kind of get a 12 blade black there. And I was able to block it better with a packable composite. And you just have to make sure that you don't overbuild it because then the matrix won't fit. So once I felt comfortable about blocking that area and closing the diastema a little bit with the packable, I went ahead and finished it off with the injectable matrix. And you can see most of the excess or all the excess on the facial. So you just go ahead and use a 12 blade to remove that. The series saw I use every time I do any kind of composites to open up contacts and polish in between. That's what you're looking at. A few weeks afterwards, which I saw her the other day for a recall, and she was incredibly happy. Now for posterior teeth, this patient presented me after ortho, and I think this tooth was, ankylosed, it wouldn't come down. So you could do the same exact thing on posterior teeth. I went ahead and, again, make the design, make the matrices. A few little tricks here. One way is that if you have a hard time getting a Teflon tape through a contact, then you could wedge it prior to kind of create an opening and then place the Teflon tape through. I removed the sealant and removed a little bit of staining, but it wasn't carious, so I wasn't very aggressive about it. You microbraided it, get ready for the bonding etch adhesive. Go ahead and inject that in. You have some of the excess everywhere on the facial and on the interproximal, which, we're able to clean again with 12 blade or 7901 carbide burr. Add a little bit of oak hair and or yellow and brown tinting here on the occlusal, pollutioning here it. And and that sort of takes care of that. And it's no prep pretty much, or very minimal prep, right? And it's a very minimally invasive way of restoring occlusion. And that's what it looks like after a couple of weeks. You could see how the material blends really well. And I don't do much shade selection anymore because a lot of the stuff has a chameleon effect. I do more layering if I want better optics. Then I worry less about shade. I don't know. I mean, if it's A1 or A2, it'll pretty much work, really well in this case because it just has a chameleon effect. It absorbs the color of the tooth and kind of changes because of that, and absorbs that color. And you could just use it for your day-to-day class twos as well. This is a simple class two case. That we used it for, and I really like it for marginal ridges as well because the material doesn't really flow too much. It kind of stays put for cusps as well. And one thing that I started doing a little bit more recently is I etch before I place the matrices on, just so I know etch gets everywhere where it needs. So I want to get past the matrix, just so I know that it's fully etched there. And one of the few times I use a Toffelmeyer is when I do back-to-back restorations. The first one for me is always going to be a Toffelmeyer. And I typically use I do the smaller restoration first because I have better access. You could use two different layers. You could use a diamond layer, then an enamel layer, or just use all one shade, like an enamel layer. You could polish the excess, and then for the second restoration, to get a better contact, I use a Garrison matrix, and I do the same exact way. So let's talk a little bit about another way I use injectables, and I use them now pretty much predominantly for my luting agents. The way I cement or lute my veneers and indirects. So let's briefly talk about the way I condition the porcelain. I never let my lab etch it because I just don't know how long they do. I like to sort of micromanage. And depending on what it is, if it's Emax or if it's feldspathic, I etch a little differently. This is the protocol I use for etching my ceramic. Feldspathic, you have to do 9% hydrofluoric acid, and you do it for a little longer. Lithium disilicate, you don't have to etch as long, and you need 5%. So it's that red color etch. After that, I use phosphoric acid, blue etch, and I use that for about a minute. I kind of scrub it in there and just try to remove all the debris. After that step, I throw in an ultrasonic bath with distilled water, or sometimes I use alcohol for about 5 minutes. I just kind of let it there and let the timer go. You could also use Ivy Clean as well. I use that sometimes as well. Once once the debris looks like it's all removed from the porcelain indirect, then you silanate it and get ready for the bonding agent. Now I place a little bonding agent on the veneer, but I don't cure it. I just kind of let it thin out there. If you're using let's say optimethyl, you don't, just let it in there. If you use like a universal, you have to air dry it. And if it's let's say if it's going to be G2 bond and you're only using the bonding, just add a little bit. You don't necessarily need to air thin that. There are articles showing how you really just needed to remove the debris of the porcelain, which is why I take all these extra steps. There's a lot of research on there too, where preheated composite, doesn't really affect the seating. A lot of people get nervous about it, but if I use preheated composite, I use a calcite warmer that heats up my composite, and you have to make sure you aerate it, and that creates enough space for the luting agent if you're going to use preheated composite. So, and make sure it seats all the way. When you air braid, you creating more gaps into the restoration and into the tooth or the whatever if you did need done sealing. So you don't worry about the seating of the restoration afterwards. But injectable is, I feel more secure about it seating all the way. And to me, it works really great in my hands. I don't get the material everywhere. It's one thing that I might do differently in maybe more of a true biomimetic practice where I think exclusively might use heated composites. I switch to this injectable composite. And here's a video that just kind of demonstrates how I cement or I lute some porcelain veneers. So go ahead and, place my anchored clamps on the molars. Requires some anesthetic, obviously, a little bit more. Patient was awesome. She just allowed me to film her. And, her gums, especially after being in temporaries for, 2 to 3 weeks, the gums get bleedy. So, doing it this way really makes me feel secure about how well they get glued in. We in this case we're doing an individual technique. We just make sure we floss. We're able to floss in between every contact, and before we also have to floss as well. So for the first two, for 8 and 9, you use B4 clamps, right? That's the clamp that I use. You could use a modified B5 or a 212 clamp and maybe cut it. You might have to bend it a little bit. And you can see how hemorrhaging comes out, but once you're able, or I'm able to invaginate the rubber dam better, I'm not worried about it, and I don't have to rush anything. And I'm using injectable material, so it's purely light cured. So, I could really take my time and make sure everything's in the right place, and I'm not, versus something that's dual cured, you have to rush more with a dual cured. So I love the fact that it's a light cured material. So we go ahead and, make sure all the cement's gone. And sometimes you could use fluorescent, like black light as well. And, so that helps show certain types of composites, helps shows if there's any more material left. Here I am aerabrating with my previous aeration unit, which I think works well. It's just, I like the Rondo Flex a little bit more now because it just hooks up to my chair. This one sort of you have to go get it, and it hooks up to the airline on the chair instead of the actual, like actual unit itself, which I could just leave all the time. So just, go ahead and isolate from the other teeth, especially when you're placing etch, so etch doesn't get over there. Right. So obviously we got some photos there. Have to showcase this stuff, right? So you want to make sure you could etch the front and the back. Over etch, I'd rather over etch than under etch, not in terms of duration and time, but just the surface. Anytime I do composite injectables or class 4s or class 3s, I would like to make sure I'm way past the margin. And, because you don't want to leave any adhesive or material on unetched tooth structure. So you got to, and to me, I over etch. This is the first layer of agent. I want to say that's the prime. This is surgical section that you could do to aspirate the material. It has to be, surgical section looks really, really great. Or if you want to air dry it, don't be too aggressive with the air drying because you don't want to collapse the tubules. You just want to make sure it's nice and dry, but don't blast it so much with air in my mind. Now the layer of adhesive, and we go ahead and place the veneer, and you can see how it just kind of comes out. You press it down. The instrument I'm using is from Ivoclar's, the Ultra Sculpt pad, and it's fairly easy to clean. Now, one thing is that the bonding agent, coming from this, biomimetic background and, using Optibond FL, at least in the past, I'm so used to not curing the agent, right? So like you place the bonding agent on the tooth, you place a bonding agent on the veneer, you place your cement, in this case is the injectable or heated composite, and you sort of sandwich them and close them in together and cure it all at once. You can't cure the agent, like you can't cure optimum ethyl onto the tooth and then go ahead and cement your veneer. For G2 bond or other lightly filled agents, you actually can. And the material, the bonding agent is so thin is when you thin it out, you know, it does not interfere with seeding. It's like it becomes like almost like 3 microns. So that doesn't interfere with the seeding at all. So uh, you are able to cure that before without affecting the seating of the restoration. So it kind of depends on the bonding agent, right? What you end up using. That I really do feel both ways do work. Whether if you for optimum FL, first of all, it only would work if you don't cure it, right? But for a G Premio bond or G2 bond, you could, or other bonding agents or don't have filled adhesives, you could probably go either way. You could cure it or you could leave it uncured. So here's some of the photograph snapshots: isolation, air abrasion, etching, and the bonding agents. So kind of what it looks like when the when it's inserted, you can see how it just doesn't really run everywhere. And I have that tip from the Ivoclar curing light, like a veneer tack tip. So you could just do that cure in the center, and then you could have more time to kind of clean out the excess and then do a final cure. This is now another example, and my patient was really good with her cell phone, and she selfied this the entire time. And we'll go ahead, and I think these preparations were so minimal. This is an old case, but we just used G Premio Bond, a universal agent. I mean, these were pretty much all on enamel, and we use it like the way the user manual says, is to cure it prior. So we go ahead and thin it out, cure it, and then we insert the veneers. So my posterior indirects, and like again, I don't really cut. I try to avoid cutting as little as possible. These are full coverage, but you can see how they're really just tabletop, almost like onlays. I don't try to cut the enamel on the interproximally or buccal facial lingually. I just try to conserve. I try to restore the part that's effective. And same exact concept as the anterior teeth. You seat them in. I use the Ivoclar instruments to kind of hold them down and cure it with that veneer tip, and then I'm able to more or less remove the rest. And I could take my time. I'm not rushed because it's only light cured, right? So that is huge. The fact that I don't have to rush anything when I do it this way. So certain instances now, I'm sure everyone has dealt with a case where it's a short clinical crown. These are some cases that I've done in my practice. I'm a kind of a believer of not posting teeth. I think this tooth, I think some of these teeth, especially the one on the right, had a post in there. It's a gamble, post could, fracture teeth, and you could do see a crack line on this tooth. Actually he's a patient, and there isn't a pocket on there, and he's actually a doctor, and the alternative is to pull the tooth, but so far the gums look healthy around it. And you can see how maybe crazy I get with dentin adhesion, but I feel very confident in this technique. And as long as you have ferrule, as long as I believe you could get a dental dam on the tooth, so you have enough tooth structure there to prep and get a dental dam there, I feel confident in not using a post. Because post cracked teeth, we have catastrophic failures with post. I mean, there are times where I absolutely need to do them when there's when it's fractured like below the gum line, and I'm trying to, we have this discussion with the tooth, like, hey, perhaps this tooth should be extracted, but you want to, take the risk and restore your teeth and keep it a little longer. Are you open to it? You have to have that talk, right? with them. You have to give them the expectations. And this is the material I use, the EverX Flow. Has short fiber particles, and it's the strongest, I believe, the strongest restorative material in the market. Now, you just cannot use this at the outermost layer, so it's supposed to act as a core buildup or a post replacement. And the fiber reinforced material makes it so it avoids these crack propagations, like maybe some conventional composites do, or certainly post do. So same sort of scenario. I like to etch. I don't know why. It depends on the bonding agent, but I still like to etch at least briefly my dentin. You're allowed to etch, but you don't want to over etch it. So to me, it helps. I feel like it helps clean and disinfect the area. And you always have to use a two-step bonding agent here. I would not use a universal agent when I'm trying to get maximum dentin bonding. And so G2 is my go-to for cases like this. And you can see how I could, with this type of curing light, like the veneer curing light, I actually use this a lot for my core buildups, post replacements. I'm able to really get in there and cure that buildup material and the composite material really well underneath, sort of underneath into the whole, the chamber of the pulp chamber of the tooth, into the actual canal. And I restore the teeth with the FiberX material, and under the dental dam, I glue these restorations in. So you see them like so. Thank you again for your time. That concludes our more or less case examples that I do in my day-to-day practice. I hope some of you guys learned from it. I hope this was useful. And yeah, feel free if you have any questions, you could send me a message on Instagram. Is probably the easiest way to communicate with me, and hopefully I could help you in any way to incorporate this in your practice. Thank you so much, guys. All right, so. All right, let me use, they have some questions. One of them is, what's the purpose of using glycerin? The purpose of using glycerin is, so the last layer of composite, because oxygen does inhibit the last curing of composite, glycerin blocks that. So you're able to get the final cure of your composite when you put something like glycerin on there. And when you polish it, I like to do this even before polishing, because if you polish it, especially with like a disc or a burr, that stuff kind of gets stuck on that, and it doesn't really polish well if debris is stuck on the burr. So I like to cure it, and then I start polishing. Now, technically, if you polish it off, then you remove the oxygen inhibition layer anyway, so you should be fine. But like, what about those little corners or little areas that you might not be able to get a polishing burr on? Over time, because that area isn't fully cured, it might stain or discolor or chip off and look unaesthetic afterwards. So I always use glycerin after immediate dentin sealing, and I actually polish it afterwards too. I always use it for my composites. I also use it when I cure my indirects, because I'm using the luting agent is a restorative material, it's composite. So I want to make sure all that's really well cured in case I'm not able to polish it with my burrs. Can you use Monobond Plus? I believe so. You could use any bonding agent. GC has been a very great company for me. I use them predominantly, and I've had great success. Even from a Biomimetic background, Optibond historically is considered the gold standard, then, SE Bond. But, using a universal agent, when I first started using it, I had hesitations. I was worried about sensitivity, worried about debonding, worried about so many things. But in a clinical setting, and I've used G Premium Bond, the universal agent, for so long that I haven't really had these issues. And I've been so impressed with it, like zero or hardly any sensitivities, because it just had a understand layering techniques, you understand dent and bonding, enamel bonding, and you incorporate some good protocols on there, really does reduce sensitivity. I don't use Bluma in my practice. I don't use glutaraldehyde because I don't need it. I feel like if you bond a restoration really well, you don't really have much post-op sensitivity. I do use chameleon composites. I feel like the generation of composites are heading that way. One of the questions is, do you use a chameleon composite in your anterior composite work as well for diastema closures and composite veneers? I do. So I use those type of composites. GC has a cord composite, and it works really well, and it's definitely if I want to do a touch more, then I might add a little bit of staining or halo. But yeah, you could use that as well. And I've done that as well, and I don't see a difference. Sometimes I like to go a little extra and add a little bit more layering just so I could have a little more trans halo effect on the incisal edges, but you don't have to. These newer generation composites, I rarely do shade unless it's a very complicated case. I rarely do shade matching anymore. All right, next question. Does it seem a bit too thick to bond and then laminate? Anything you do to make sure it's not too thick underneath? So I'm assuming you mean like the restorative material, like the actual luting agent too thick? And I don't think so. I feel like everything seats all the way. You could always heat it. You could also heat your injectable. It gets a little runny, but remember, like I like to microabrade before I start these, and that creates room for the material as well. So that is more or less. So I don't find it. I find really no issues with this way of bonding in terms of bonding these veneers and these laminates with composite, whether if it's heated composite. Now, the only time I definitely would not use heated composite is with like a thin feldspathic. Those might break under pressure. So injectable though has really replaced that for me. Do you have 5-year follow-ups? I really don't. I have a couple year follow-ups, and over the course of years, things chip. You could repair them. I show you how. I'd lie to you. I mean, to be a lie if I've never had to repair these. If I say I never have to repair these we have to repair. I do have a lot of follow-ups. If you'd like to message me on my social media, I could send you some examples. And I do recommend a night guard or Essex, just to be on the safe side. Now, for the peg laterals, not so much. But, they're coming post ortho anyways, so they're going to have to wear a retainer, so that will serve as a guard. The polishing system that I'm currently using the most, they're called Eve Diamond or Diamond polishers, Eve Diamond Diacomp polishers. It's like a purple and gray system. It's a two-step system. I get some of the best polish I've ever had in my life. And another thing that I use is a goat hair by Ultradent, like a Jiffy goat hair polisher. Any tips to prevent bubbles in your flowable? They're inevitable. You might get a bubble or two, and I get them. And I think the one thing that is just make sure you place the matrix firmly onto the tooth. And the tips of these flowables are supposed to be ergonomically or designed in a way to prevent less bubbles. But I still get them from time to time. You just have to know how to repair them when you do get them. All right. The black light I use to see excess cement is just one that I buy on Amazon. It's like one of these black lights that you could get. All right, thanks. And also, do you use fiber reinforced composite for large MODs? I do. I do use fiber reinforced composites. I first do my mesial and distal walls first, right? Because I don't want the fiber reinforced materials to touch those areas. And then the inside, I use the fiber reinforced. So the outside's packable or injectable, the walls. The inner side is then the fiber reinforced. And then I go ahead and place injectable or packable over that. And it says, is there ADA code for reimbursements from insurance? I mean, I don't know. I mean, yeah, I'm a fee for service practice. And I honestly do feel that insurance unfortunately does dictate treatment. So like if you're getting $100 or $200 for this, is it worth it? I get it. I get it. So I used to be an associate for so long. So maybe there's a creative way you could, also bill out for a base or a liner or something like that to kind of get what you feel is justifiable for the work that you're doing. Because I don't think there's a value to it. You're conserving tooth structure. And truthfully, for this to be lucrative, you kind of have to charge what you want. And it was a long road for me. I have a fee for service practice in Los Angeles, and it's a very saturated place. So I think that as long as you show your portfolio, post it on Instagram, people will come to you. And don't be scared about it. Showcase some of your cases. You'll get there, and then hopefully you'll go out and network if that's what you want. Guys, thank you so much for your time. Really loved being on here. And thank you again, Viva Learning and GC America, for having me on. Hope you guys, especially everyone in LA, is safe. And yeah, wishing everyone the best. Thank you.